Hi everyone, I'm Stephanie Robin from APNPI and Stephanie Robin Photography, and I'm here with you today to review this article that has recently been shared in many groups on Facebook. The article is out of the Journal of Physical Therapy Science and was published in 2020 and is entitled An Epidemic of Newborn Photography Poses, the Potential Dangers of Passive End Range Positioning During Induced Sleep in 0 to 14-day-old Neonates, a Scoping Review. And this article was written by Edith Nagy, who is a physiotherapist and a PhD, as well as Regina Finta, who is a physiotherapist with a Master's of Science. And so this article actually came out of Hungary, from their Department of Physiotherapy. So this would be a PhD student working with a master's degree student, and the article is a review. So there are different types of articles that can be published. And so the first thing that I think that is important for people to know is that this is not an article that is an experimentation using subjects. This is a review of literature and then using the results of what is found in the literature and what you can see in the photography community and correlating the results to the positioning of babies in newborn photography. And the reason that that's necessary, the author does actually detail this, that if you go down in this article towards their conclusion, essentially they say that I'm not actually sure, it might actually not be in the discussion section, but that it's not ethical. So it says here that, there is no research currently, no evidence of the effect of extreme cervical positions. So cervical meaning like the cervical neck area. So extreme positions would be hyperextension, which would be tipping back to a maximal degree or forward to a maximal degree. And you also have side flexion either side and then rotation either side. Those are the movements of the neck. So flexion, extension, side flexion, and rotation. Okay. And extreme positions would be at the very end of range of these positions. Now, they often reference through the article hyperextension, which is seen in the frog pose, especially if you look at the drawing that was done, that was created in order to avoid copyright imaging. But this image here was drawn from imagery found on the internet of babies being positioned. And so that would be hyperextension. You can see that if you align the baby's body upright, that the head is in fact tilted back to the maximal degree that it can go. So that is a hyperextension or an end range position into extension. And here it states right before the discussion section, so this would be within the results section of the article, it states that in vivo, which means alive, like using alive babies, evidence is not possible due to the restrictions, the reasonably strict ethical concerns. And so the reason why we can't do this is because the evidence shows that cervical end range positions while sleeping can or may cause disturbances in vertebrobasilar blood flow affecting the brainstem circulation, and it may be hazardous in later motor development. So because the research shows that these positions can compromise the circulation to the brainstem and oxygenation of that brainstem, it would not be ethical for scientists to position newborns in these positions and then measure whether or not there's an effect on the blood flow to the brainstem, because that can be very dangerous and it would not pass an ethics committee. So your study could never happen. It would be shot down in the ethics review process. So essentially the only thing that can be done at this point, because scientists aren't willing to position babies into end range positions due to the known possible risks that are included with that movement, the only thing that can be done is to do review of literature. So that is what this is. This is not an experiment where they've positioned babies and then measured the blood flow. also, this is a review of literature that suggests to us what we could expect with those positions. And so sometimes in the article, you will see them reference research that's been conducted with newborns that unfortunately have passed away. So cadaver research. And so when they talk about basilar blood flow or the atlanto-occipital joint and slippage of that joint, that all has been researched with cadavers. And I know that's uncomfortable. Nobody wants to think about that, but many, many, many of the advances that we've made in science, in medicine, have been from research with cadavers, because ethically it's not possible to conduct that research with live participants. And so we learn from the human models of the cadaver. And so there are definitely risks and dangers with end range positioning. Primarily, the authors seem to focus on hyperextension and the hyperextension that is seen in the frog pose. However, they do mention a few times within this article that that is just the tip of the iceberg. So they say a huge number of unnatural positions can be seen across social media using passively produced and maintained, often end range cervical spine positions. And so even in the case of the positioning where a baby's head is into the side, so sometimes when you see the baby's head oriented sideways to the body, so the body seems to be going in one direction and the head in the other, that as well is an end range position. And so essentially what we want to do is we want to look at the results of this article. And a lot of what I'm seeing that people are commenting on online in order to discredit the article, they're saying things like, well, this is not a well-written article. I would disagree, having read many, many articles, through my master's degree in physiotherapy and also through my career as a physiotherapist. The Journal of Physical Therapy Science is a reputable journal that is listed in many different resources. It's a professional journal, and it has a review process. So you cannot just submit anything and have it printed. So you would have had to have gone through, so the editors here that you see, they would have had to have taken this to their advisory team in the Department of Physiotherapy at their university. I don't know how to say this, CEGED, Faculty of Health and Social Sciences, and this is in their university in Hungary. So it would have first have to pass through the advisory team there before being submitted to the journal, which this article was submitted December 7th of 2019, accepted August 9th of 2020. So what that means is that this article was submitted to the journal in December 2019, and 8 months later, after it had gone through proper review from the publishers of the journal, who then deemed that it was appropriate to print. That's how long it would have taken for this article to print in the journal. So articles are not generally printed willy-nilly. They usually do go through review processes. Additionally, because this isn't a study that's been done with live newborns in newborn poses, they didn't have to look at, okay, what were the methods sound that were used in order to create these results. So essentially what this is, because it's a scoping review, like we said before, it's a gathering of information and application of that information to this field of newborn photography in this case. So let's get into a little bit of the nitty-gritty here. These articles can be difficult to read if you don't have a good understanding of physiology, because words like somatosensory or atlanto-occipital joint, might be a little bit I don't know, just confusing perhaps. So a good understanding of those terms, is necessary in order to read through this article, I would say. And I think that, sometimes you can get lost in that and it becomes difficult to read then to make it through the entire thing. So I think sometimes, and this is my own presumption, but some of the commentary that I'm hearing in other groups on Facebook perhaps is coming from people who may not have have read through the entire article or may not understand the article that they are reading. Certainly as a master's of physiotherapy myself, I do not deem myself educated enough to critique the review board at the Journal of Physical Therapy Sciences or the PhD and their advisor who found this article appropriate and professional enough. So I would not comment to say that this is not a professionally written article, because I don't have that type of education, and you know, I wasn't there on the review board when these the people that, you know, published this magazine deemed it a sound article. So I'm going to, you know, default to the fact that, you know, that's their job. And I think that they are smarter than I am, and that they have a better sense of what is appropriate to publish and what isn't, and that this is a sound article. So that's the assumption that I'm going to hold here, because, you know, I like to refer to the experts in their fields, of which I am not in this case. So what we're looking at here, I know a lot of other people will say they're very confused about what is being discussed about white noise in this article. And so the author in this case has chosen to bring in the ethics of whether or not it's ethical to lull a newborn into a deep sleep using white noise. And for the reason that when they are in this deeper sleep, it will affect their ability to modulate pain. And also it's going to affect their ability to react in terms of their tonality of their muscles. So newborns have reflexes that are meant to keep them safe. And some of those reflexes are present at the level of the neck. And so in terms of positioning, where you're going to position a baby into this end range or hyperextension or such, newborns generally tend to have a flexor response where they will protect themselves by bringing the neck back out of those hyperextended states. And yes, you will hear people say, you know, well, my baby gets, you know, is breastfed and their head is cocked right back like that as they're feeding. And that can be true. However, there is a difference in the way in which the head is supported when it is being held by your hand for nursing, or against a nursing pillow, inside lying, or however so they are positioned. But generally the heads aren't lying free-nilly, and just the full weight of the head you know, pulling the neck back. And so in the case where we're posing the babies, you can say that, yes, we have hand holding available. So we are hand holding the babies through their heads and offering that support. But because they are in that upright position now, and because you have that immature atlanto-occipital joint, there can be some slippage there in between the vertebra, which can be a little bit dangerous, actually. So what is that joint? What's going on here? What are we talking about? You're talking about the highest joint at the top of the spine, between the skull and the spine, essentially. And so in a newborn, that joint is a little bit immature, and they do talk about the fact that it's primarily unstable, where you can have adventitious sliding and slipping movements between the vertebral column and the skull. Okay, so, and that's in cadavers that they've found this. So they've taken cadavers and tested them for movement at the joint, and the joint is primarily unstable when you're looking at a newborn versus another cadaver of an older baby or child or adult. So in 10 of 17 infants, the posterior arch of the atlas inverted through the foramen magnum during extension of the head on the atlas, resulting in the anatomical potential of bilateral vertebral artery compression. What does that mean? So it means that in 10 of 17 babies, the posterior arch is the back part of the vertebra. So each vertebra has a hole in it, and that hole is where the spinal cord is going to travel through. And so they're saying that that back arch has slipped forward, okay, that way towards where that spinal cord can run through. Now, at this level, at this high level, we're talking about brainstem matter. That's not the spinal cord in that joint area. It's the brainstem, because the brainstem is here at the base of the skull. And so that is where the top of the, spine starts. And essentially what can happen is that you can compress with that posterior arch as it comes forward and puts pressure onto the brainstem. That's where you can compress the arteries. And so if you are in fact compressing arteries, then there is a danger that you're not going to have the proper blood flow in that area. And so at that point, you could suffer from hypoxia, which is a lack of oxygen to the brain due to that. Okay. The other thing that they discuss here is that the white noise has like a pain modulatory effect. So essentially that in using white noise, you're lulling babies to sleep. And so as you do that, your chance, it says here, that your likelihood of a baby falling asleep is increased more than threefold, from 25% to 80%. So in using, the white noise, essentially you're going to have your baby induced into more of a deeper sleep. And now we know that deep sleep with newborns has a pain modulatory effect. Okay, that's been proven in medical literature. So there is this analgesic property of white noise. Analgesic means almost like painkiller. It's kind of like taking Tylenol or something. So the other thing that you would kind of sense pain with, I guess, would be your somatosensory system. But in newborns, this is immature. So somatosensory would be like little receptors that are within the muscles, and also you have your vestibular perception too. So most of these are in fact immature in newborns. They don't have good body perception, and they have very little postural control. Those are things that develop after birth. And so, I think what they're getting at here is that because you're putting them into a deeper sleep, they might be in the REM type of sleep where you have a loss of muscle tone. So we all know that, when babies are quite sleepy, when they're in a good sleep cycle, that they become floppier, more malleable. And I suppose the problem with that is that it also numbs spinal reflexes and the regulation of your body temperature. Okay, so those things are maintained if you're in a non-REM sleep, but once babe's in that REM sleep cycle, they're going to have a decrease in their ability for the reflex to kick in to help control the positioning of their neck. So if you put them into a hyperextension when they're in a non-REM sleep cycle, they should be able to pull themselves out of it. However, if you've lulled them into that deep REM cycle, that reflex is not going to be as present. And so they won't necessarily pull themselves out of their reflexes are numb. So asymmetric tonic neck reflex and the others that are cervical reflexes are going to be numbed. So they're not going to pull themselves out as readily of a position that can be dangerous to them. The other thing is that if it is painful at all, because they have immature somatosensory sensation and because they have pain modulatory effects of white noise, so that analgesic effect we talked about, that they may not show you. So usually with newborns, we look for facial expressions or a cry, and those will be muted. So they wouldn't show you the same response that they might if they weren't lulled into a sleep state from white noise. So I think that is what the author is referring to, or authors are referring to, when they talk about the white noise and the use of the white noise. So I know that we all have a bit of a love affair with white noise machines. And in this study, they do talk about studies that were done and how it was determined that white noise has this pain modulatory effect on newborns. And they did do it in this pinprick situation where they're, like the blood draw on the heel that we often see done with newborns. They did it in different scenarios with newborn on a mother's lap, newborn on a mother's lap with white noise, newborn in a cot crib situation with white noise. Cot crib with white noise was where they had the least amount of reaction to the blood draw of the heel. And I think they were using 100 decibel white noise, whereas we would recommend, that you're using way less than 80 decibels, because the American Academy of Pediatrics, has designated a hazardous zone for newborns as 80 decibels or above over a 4-hour period. So because some of our newborn sessions are running a little longer here at APNPI, we do recommend that you're using a lower decibel sound. So I'm not sure the effect of that on pain modulation with newborns, whether the amount of decibels has anything to do with that. But in any case, it's that is what's brought in there when she's talking about, white noise, and what does that have to do with this article? Okay, so the other things that I've highlighted here essentially are just that, again, I wanted to remind you that here they state, in medical studies, the potential danger of extreme head positions of the neonates are out of question from an ethical point of view. Hyperextension of the cervical spine can cause bilateral compression of vertebral arteries during early infancy. And that has reference numbers on it. So when they make a statement like that, you're going to see that there's going to be little numbers beside it. And those numbers are going to correlate with your reference list. So if you go to the reference list 6 and 7, you can see studies numbers 6 and 7 is where that information came from. So infantile atlanto-occipital instability, the potential danger of extreme extension, in the American Journal of Just Child. This is from 1979. This is a long time ago that this was found. Vertebral artery compression resulting from head movement, a possible cause of the sudden infant death syndrome, in the journal Pediatrics from 1999. Those were the two references that were used to come up with that statement that hyperextension of the cervical spine can cause bilateral compression of vertebral arteries during early infancy. So you can see that this author didn't just state that just out of their head. That is documented research. And so anytime that you see those little numbers come up in the article, it's referencing another article that has been done, another study, that's where that information has come from. Okay. Additionally, we see here the rotated head position during sleep, especially rotation in prone, can cause position-dependent circulatory disturbances in the vertebrobasilar circuit. So, that also is concerning, because that's saying in a prone position means on their tummy, with rotated head means rotated. This is rotation. So I can think of many different positions in which we have babies on their tummy with a rotated head. And so that's another thing that you're going to want to avoid, that extreme rotation of the neck there, because it's stating that is a potential for, a hazard for brainstem circulation. Okay. Inborn postural mechanisms in the newborns are different in awake versus asleep states. Here, what we're saying here is that, when a baby is awake, they have a different ability for, processing their somatosensory stimuli. So visual stimuli, as well as, the stimulus that you feel in your kinesthetic sense. So that means there's little receptors in your muscles, tendons, and tissue that will tell you where you are in space. So if I were to close my eyes and stick my arm out, I know that my arm is pretty much parallel with the floor and probably directly out from my shoulder. And why do I know that? If I can't see it, it's because I can feel where my arm is in space. Okay, so that sort of ability to feel where you are in space and time is heightened in an awake state and muted in a sleeping state, which I'm sure you're aware of, because as we sleep, we don't know where we end up in our positions. Okay. Cervical end range positions while sleeping may cause disturbances in vertebrobasilar blood flow, affecting brainstem circulation that may be hazardous in later motor development. So here we've added just that little tidbit of information at the end, in later motor development. So they're stating that, if you reduce the blood flow or the circulation to the brainstem, that later on these babies can experience motor delays. So whether that's a fine motor delay or a gross motor delay, if you've had children of your own, you will know that, sometimes they're later in picking things up, walking, crawling, pincer grasp, like these are all fine motor or gross motor skills that typically come at certain set times. But of course, there's some individualization. So usually when we're looking at pediatric physiotherapy, there's a range of what is deemed to be normal. I don't like that word, but what is usual for what you will see with a newborn as they're developing. And sometimes you can have, fine motor delays or gross motor delays. And those are sometimes associated with other conditions. But what they're stating here is that possibly if you were to restrict blood flow to the brainstem at a young age, that it could have an effect that's seen later in motor development. Okay. So in the discussion section, they state that the minimum requirement for passive mobilization and positioning are the basic anatomical, physiological, normal movement knowledges and the non-maleficence principle. So they're saying that that is needed in order to be competent in positioning a baby. So I think what the authors here are trying to state is that as a photographer, you should have a basic knowledge for passive mobilization. So as a physiotherapist, you certainly are not allowed to go out into a practice and start mobilizing joints or necks, especially on clients, until you have a good understanding of the mechanics, the anatomical and physiological makeup of the person's body, because these passive movements, they're different than active. You're doing it without the person initiating the movement themselves. So you're using your hands and you're taking their head into different ranges or mobilizing their body and their joints in different ways without their active help. So I can lift my own arm up this way, right, over my head. So that's an active movement. A passive movement would be for someone else, not me, but someone else to come and move my arm, and they're moving my arm into that position. That's passive movement. So if they were to let go, that arm would literally just fall. There's no active use of the musculature. Now, when you do actively use your muscles, the joints act differently than when you passively move a joint, right? So there is some protection afforded by the fact that the muscles are engaged. And when we're passively moving a joint, the muscle engagement is not happening. So you're getting a little bit more of the movement in the articular surface of the joint. So deeper in the joint and in the bone and capsular structures of the joints, right? So essentially what they're saying is that in order to move subjects passively, that you should have a base understanding of the anatomy and physiology and what those normal ranges look like. So what is a normal range for flexion or extension or side flexion or rotation? And that goes for all of the joints, right? So any movements for any of the joints that we're moving, you should have a good understanding of what are the limits here and what should the end feel be like. There are different types of end feels. Some are bony, some are tissue approximation, some are spongy feeling. So you should have a good sense of that in order to move passively a body without harm. And so that's that last part. So that non-maleficence principle. So do no harm. It's the same thing that you hear with doctors, right? So before they're allowed to practice, their first principle is do no harm. First, do no harm. So in order to not do any harm, you have to have an understanding. And that's, I think, what this article is about. Really, it's about making sure that people who are working with babies and newborns and passively moving them into ranges first do no harm, and that they have the training and understanding of those joints and how to move the joints and what dangers are associated with that. Okay, so here in the discussion, it also states that the noise perception has priority over somatosensation, meaning that for newborns, when they are, reacting, the noise stimulus is actually important to them, more so than somatosensation. And that noise stimulus is going to be numbed with the white noise machines. Immature somatosensory information is blocked when you are using this white noise, and as well REM, putting them into the REM sleep cycle due to atonia and the closed gates in the thalamus. You're going to, have less muscle tone in the joints, essentially, or around the joints and the muscles. And these are further masked by exposure to white noise. So that question that they're bringing up there is whether or not it's ethical for us to use the white noise in order to lull them into these states where they have less ability to react to passive changes in movement. The other potential hazard is brainstem hypoxia. We've been over that. It says it's neither visible nor detectable during the photography sessions, and even periodic breathing patterns are sometimes misconstrued as being simply cute. And so they did bring up in this article at some point, it's a little bit later, that the movement from breath and heartbeat related movements. Okay, so when you see the newborns positioned in frog pose or another pose where they're a little bit upright, and as they breathe or as their heart is beating, you're seeing this little movement at the level of the head, just this little like boop, 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 boop. It's a little reaction, right? So essentially what they're saying is that movement can deteriorate the position of the neck. So it can cause further slipping forward of that atlanto-occipital joint. But here where they say, the changes, the hypoxia, so the cutting off of oxygen is neither visible nor detectable. So we can't see it, right? And we can't detect that it's happening. And that even periodic breathing patterns, because sometimes when you do go into a hypoxic state, your breathing will pick up. You'll pick up more quickly, or you'll try to gasp, or you'll hear like little squeaking sounds as they're breathing. And those can be misconstrued as simply being cute. So I've seen that too, where people will see babies sitting in potato pose, let's say, especially unsupported, and they're doing a little jerky movement, and you hear the whiny breath coming in and out. It sounds like they're kind of whining a little bit or wheezing. That actually can be a sign of hypoxia rather than acute preemie breath, or, not to worry, my preemie did that all the time just because they have a narrow airway. I think, it's one of the things that we need to be aware of, so that when we see that happening in our client, we can move them out of that position and put them in a very natural position for them to breathe more easily, or ease up, if we've wrapped them, ease that wrapping around the rib cage so that they have good free expansion of the rib cage, because that breathing, while typical sometimes for preemies, certainly isn't usual, and can also be a sign that they are struggling. And so while it can be cute, or it can be usual, or mom might say, oh, that's just them, they do that all the time, that's great, but they're in our care. And I think when they are in our care, we should listen to those, we should see those little cues as possible signs. So if you're working in physiotherapy, let's say, and you're working with a person's shoulder, and they'll say, oh, that clicking or that whatever, it happens all the time, that's nothing to worry about. But it is something for me actually to think about, because I don't want to danger, first do no harm. So I have to ensure that whatever is happening in that joint or in that space is happening safely. And so perhaps I'm not going to take them into a range where they are going to experience that click or that slip that they're used to, because it's outside of what's considered normal for the joint. And so that breathing is outside of what's considered normal for newborns. And so when you see that, that's an indication that you should act, that you should try to alleviate any tension or pressure on the baby that might be causing that breathing pattern. Okay. So in the froggy pose, a big concern on the hyperextended passive position of the upper cervical spine. So what you see there, hyperextension, again, is going into that very end range of the extension, which often you'll see when babies are positioned that way with the head up, okay? And then we talked about this already, further deteriorated by the breath and heartbeat related extra uncontrolled movements of the head, as well as passive weight bearing on the bones and joints of the upper limb, and the passive reaction forces acting on the atlanto-occipital and other upper cervical joints, and uncontrolled accessory movements in joint positions. So, I think that what they're saying there is that there is a lot of risk when you're putting a baby into a pose like the frog pose, a lot of risk. And they call for a wider debate on the role of medical professionals to control and regulate the dangerous practice that they're referring to of moving necks into end range positions. Okay. So from the aspect of pediatric physiotherapy, in case of any delay in motor development, retrospective investigations should aim the history of photographic extreme positioning in newborns to provide more evidence about the research gap. So what they're saying is when you notice that there is a motor delay, that it would be helpful if they could go back into their history and see, did they do any of these extreme positions in newborn sessions? And that's a way to correlate that, okay, if we're seeing that a lot of patients who have motor delays also were positioned in these extreme positions during photography sessions, then possibly there is a correlation between the two. Causation, correlation, aren't the same thing. And of course, because of ethical reasons, we can never, you will never see scientific research done with newborns, live newborns in typical newborn poses to research whether or not that, you're cutting off blood flow to the brainstem, because there's already research from as far back as 1979 that shows that hyperextension can put pressure on the structures at the level of the brain stem, causing hypoxia. So because scientists already know this, they will never willingly put newborns into hyperextension, okay? Because it has an associated risk and it would not be ethical to do so. So that to me says, if a scientist would not be willing to put a baby into a position in order to figure out whether or not that position in fact is dangerous, because there's enough evidence already to say that the positioning is dangerous, should we be doing it? So yes, this is a review and not a study, because studies will never be done with live newborns. But it brings up a lot of issues that I think are important for us to consider and to think about. And in this article, I think at some point they state that, we suggest the neutral cervical positions and natural poses for photographic purposes to avoid any passive interventions and end range positioning. So essentially what the authors are suggesting is natural posing in which those really end range positions of the neck are not necessary or seen, okay? And I can understand why they would suggest that from a medical point of view. And I myself do not do poses in which babies' necks are in these end range positions for this reason, because of the innate dangers. This article does not even consider positional asphyxiation or, the effect of the airway in extreme positioning of the neck. And I can only imagine that in future further research is probably going to come out and be published. This is a fairly recent article. We would consider it recent because it was accepted August 9th and then printed in August 9th, 2020 and printed in the 2020 journal. And, submitted in 2019. So it's possible there are future articles, waiting to be published that also have to do with newborn photography poses. And so myself, in order to err on the side of caution, because we are starting to see articles coming out in journals with concern from medical standpoint, like people who study movement, who study neonates, and we're starting to see concern in the medical community for these practices amongst newborn photographers, that, that's enough for me to decide not to offer those poses. I think there are many multiple ways in which we can provide a varied portfolio for our clients. And, I think that it's important for us to think about what is our purpose as a photographer and what are the risks that are necessary for our clients and their babies. What is necessary risk in order to complete a session? And is it possible to complete a newborn session without putting babies into positions that medical researchers would not do because of ethically based decision making? So they have enough evidence to suggest that those positions are dangerous and can be dangerous, that they wouldn't themselves position a baby in those end ranges. So should we? I think that that's the main question that's coming out here. And for me, I don't look at this as, negative for the community of newborn photographers. I look at it as informative. These researchers have pulled from other researchers' work, and you can see within the chart here that they've looked at many studies. There were 11 studies that were included, and here are the summaries of the studies on these 2 pages. Okay, so they've looked at 11 different studies in order to compile their reasoning for this article. So these are not biases that are being presented by these 2 practitioners and researchers. It's sound advice based on prior medical studies that have shown up in a Journal of American Pediatrics. And so those are pediatricians that are, PhD pediatricians that are then writing those articles and providing the research for those studies. So this is a compilation of different resources and, taking from that compilation of evidence and applying it to the field of newborn photography. A lot of people will say that this article is not sound, that it's some biased person's opinion. It is not. They'll say that it's not peer reviewed. It has been reviewed by the Journal of Physical Therapy Science in order to be published, and by the advisory team of these physical therapists that hold PhDs and master's degrees. So I think it has been reviewed, but you don't peer review a review of literature because there was no study done here. So a peer review of a review of literature is not needed. Peer review would be needed for the studies that they've referenced, which I'm sure has happened. People will show you pictures of things that they'll say will justify this. Well, here's how an African mother will hold a baby traditionally in a sack on their back, and their head is lolling about. But when you look at those pictures that people are sharing, my questions start with: are they newborns? First of all, are they 0 to 14 days old? Is their head held in hyperextension, which is this, again, that movement? Or is it some combination of side flexion, rotation, flexion, perhaps, that their head is in, and not quite extension? Or, partial extension with side flexion rotation. So not in the end range of any of those, but in a combination of movements. So you want to think critically when people provide you with the reasons why they think the positioning is fine. I tend to want to listen to the research and the people who have done the research, because to me, they're the experts in the field, and I don't consider myself more expert than them just because I have experience handling hundreds or thousands of newborns. Again, it was pointed out in this article that you can't tell. You can't tell if you're cutting off the circulation when they're in that position. So you can't tell if you've had that slippage of the atlanto-occipital joint between, skull and that first vertebra, whether that slipping is happening forward and cutting off the circulation to the brainstem. So if we can't tell if it's happening or if it isn't, perhaps we should avoid doing it. That, I think, is the sense of this article. I think that's the purpose of why the authors brought this forward. And I think it's a worthwhile stance. And so you'll always find people that will say, no, it's fine what I'm doing, and I'm not doing anything wrong, and I'm fine because some doctor or nurse somewhere told me that it's fine. Again, I wouldn't go to a cardiologist to ask about an ear, nose, and throat issue. I wouldn't go to a podiatrist to find out about my heart valve dysfunction. And so why don't you reference a pediatrician that works with neonates, who has stated this, or a respiratory therapist, or someone who manages passive range motion, like a physiotherapist. if people in those positions who work with newborns daily have concerns, or who have the knowledge of joint function and passive range mobilization, if they have concerns, I'm going to listen to them more than I'm going to listen to your family practitioner who said everything's fine, or the nurse at the local walk-in clinic. You know, I would much rather listen to someone who has the experience and has gone through the process of attaining a degree, a PhD, and reviewed their research through, you know, their advisory board, and then further through the panel that approves articles to be published in things like this journal. So that's my stance on this article. I hope that that little breakdown, although long, hopefully was informative for you. This article is linked within our group. I'm not sure if it's going to show up backwards, but again, it's been published by the Journal of Physical Therapy Science, and the review article is titled "An Epidemic of Newborn Photography Poses, the Potential Dangers of Passive End Range Positioning During Induced Sleep in 0 to 14-day-old Neonates, a Scoping Review." And so you can go and you can look that up and read through it if you like. And I'd love to discuss with you if you have concerns or another viewpoint. I'm always open to hearing it. And I hope this has been informative for those of you who don't feel like reading through an article like this, and that we can, you know, put the advice that is held within into practice. And so we're going to discuss at APNPI how we can help assist with that as well. All right, have a great day, everyone.